Hello there. How comfortable do you feel about air travel? I'm guessing the answer is very because it's one of the safest modes of transport we know of. An airplane cockpit can be a particularly intimidating place. What if I told you that your pilots weren't quite sure about how some of these dials and gauges worked? As a passenger, would that make you comfortable? I'm guessing not. But that's unfair because in the OR, day in and day out, we subject our patients to surgery, we burn, char, and electrocute them without truly understanding how any of the devices we use in the OR work. So when things go wrong, as they sometimes do, we are kind of left out, scratching our heads, wondering how things can be improved. These type of images from dispersive electrode injuries are far too common. It's not just this, but there are delayed presentations of visceral injuries that we hear these horror stories about. It's very easy for us to think, no, this cannot be happening to me, or rather, this does not happen to me. But the fact remains that numbers are very high, and invariably, most of us will get stuck. 1 to 2 out of every 1,000 surgeries has suffered some form of electrosurgical injuries. These sort of delayed presentations on viscera are particularly problematic to treat because protein gets denatured and undergoes necrosis over the course of a few days, which means just because the immediate post-operative period has been smooth, there's no guarantee that it is going to stay smooth. You may be thinking that 1 to 2 out of 1,000 is not that high, but think about the sheer number of procedures we perform in our centers, our cities, our states, country, and all across the world, and you'll get a better idea about the sheer numbers of iatrogenic injuries I'm talking about. Electrothermal injuries can be detected almost 2 weeks after surgery. That's a very long time. Almost half of the iatrogenic bowel injuries by electrosurgical energy are unrecognized, and of those that go unrecognized, the fatality risk is over twice that of those that got picked up at the time of surgery. This makes sense because of those patients that have had delayed presentations, over 70% of these guys are going to require some form of reoperation. These are staggering numbers. There was a group in France that voluntarily collected data from surgeons, and they found that 88% of surgeons over the course of the study reported some form of electrothermal injuries. And if you ask surgeons whether they themselves have been burned or know somebody from their team who has, more than half respond in the affirmative. There are several great things to be gained from the correct use of electrosurgical energy. Some of the immediate gains are obviously there's going to be less bleeding in the OR and it's going to lead to a shorter operative time. But there are a few lag measures that we forget. When things go well, the overall risk of complications gets reduced as a result of these devices. Lesser blood loss at surgery also means fewer blood transfusions and all of those complications. The total length of hospital stay significantly goes down. It leads to lower costs, eventually lower mortality. If you take a closer look at the energy devices and try to make yourself more intimately aware of how they work, when things go wrong, you have a stronger place from which you can improve. I know of no postgraduate training programs anywhere in the country where a significant amount of time is dedicated to learning about these devices. But the devices themselves are undergoing change and innovation at a frightening pace. I mean, this progress is not stopping for anyone. And as the end users of this technology, I think the responsibility lies squarely on our shoulders to update ourselves and keep ourselves abreast with all this technology. Trying to become competent by means of osmosis just because you use these devices day in and day out and you've used them for so many years does not necessarily take you down the path of mastery over them and true surgical skill, correct? At the very least, it is disrespectful to the innovators who are making this technology for us. But honestly speaking, I think it's a greater disservice to the patients who we subject to surgery on our operating tables, because when things go wrong, we are not perfectly equipped to deal with these injuries. You need to make an effort to update yourself or risk being caught out in the OR asking, oh, what does this button do? I am Eham Arora and I come to you from Grand Medical College and Sir JJ Group of Hospitals in Mumbai. And this is my guide to surgical energy. So the first question, what is cautery? Is it the devices that you're sitting and using in the OR? Honestly, no, that's not cautery. Cautery deals with the direct application of heat. So this tong that you're seeing on your screen right now, that's been heated in coal, that's cautery. When you brand livestock on farms, that's cautery because that's heated metal being applied to the skin. Okay, so cautery may not be the right word. So what's electrocautery? That has to be correct, right? Not really, because technically, a clothes iron can be electrocautery. It's the same thing. It's the generation of heat by means of electricity. Yeah, clothes iron is going to cut the cake, right? Cautery is actually a very wrong term for the devices that we'll end up using in the OR. The correct term that we should be using is electrosurgical energy. And within this comes several different technologies. The first of which is radio frequency, ultrasound devices, lasers, microwave, and then finally passive heat transfers or cautery, which to my knowledge are currently only being used in ophthalmology and ENT. Nowhere in general surgery do we actually land up using cautery in the true sense of the word. So I'm going to be dedicating a large part of this presentation to radio frequency energy devices because they are the biggest part of what we do in the OR. So why is it exactly called radio frequency energy? Well, every form of electrical energy has some frequency attached to the current. So it could be a waveform or could be the electrical alternating current. So the electricity that we get out of the wall sockets is at 60 Hertz. Muscle twitches at about say 100 kilohertz, or rather I should say stops twitching at that frequency. And then finally around the 5 lakh hertz mark, we get the electrosurgical energy that we'll end up using. It's called radio frequency energy because it is extremely close to AM radio frequencies that we'll end up listening to on the car. Beyond that, of course, you have the frequencies that are utilized by television and even our 3G and 4G networks for our phones. What exactly does alternating current mean? Well, it means a current which is rapidly changing back and forth around a baseline. When we're talking about the current that comes out of our wall sockets, the frequency of alternation going back and forth is 60 Hertz or 60 cycles per second. So this is essentially what happens. Within a wire, the polarity is constantly being changed from positive to negative, as a result of which the blue electrons that you see on screen keep alternating back and forth, back and forth. What ends up happening is this oscillation of ions causes constant collisions with other cells within the conductor material. These collisions eventually produce frictional forces, and this friction produces thermal energy. So let's take a more panoramic view of what exactly is happening. So we are applying electromagnetic energy across a conducting device. This electromagnetic energy is converted to kinetic energy of the electrons, and that kinetic energy then leads to thermal energy, which is what our desire is with electrosurgical energy. This alternating current is not like the current we find in our wall sockets. This is at 5 lakh hertz, extremely rapid. Now, before I take you guys any further to discuss the effect that different energy devices have on cells, we need to talk about at what temperature cells behave in any particular way. It's only then that you'll be able to clinically correlate what exactly is happening. So at 37 degrees Celsius, the normal temperature of the human body, everything is hunky-dory. The cells look fine, there's no problem. But say you hit 50 degrees Celsius and sustain that for 6 minutes, you're going to have cell death. Now, this cell death is not going to be dramatic. The first thing that's going to happen is that the cell wall gets damaged and it becomes extremely leaky, as a result of which several ions, proteins, and fluid rush out, and eventually the cell size reduces. The cell may retain some of its normal architecture, but at these conditions that I am discussing right now, 50 degrees Celsius for 6 minutes, this cell death is irreversible. We are not going to get anything out of it. Say you increase the temperatures a little further, 60 degrees Celsius. At this time, you don't have to wait for any period of time. Cell death is instantaneous. We keep increasing temperatures beyond that point. So remember, I said at these temperatures, the cell may retain some architecture, correct? Up to 60 degrees Celsius. But between 60 and 90, there occur significant architectural changes. There's protein denaturation and coagulation, for which you'll have to think back to what you learned in biochemistry in your first year of MBBS. Let me just simplify the entire thing for you. The proteins are having these tertiary and quaternary arrangements where they are folded upon themselves in a particular way. When you apply heat, these protein molecules open up, and when they cool, they do so in an extremely haphazard manner. So essentially, this is what lands up happening. Without the application of heat to cells, all of the proteins are contained within the cells themselves. When you apply heat, the cells reduce in size. You find all of these little protein molecules are now leaking across the cell wall. Some are going out into the interstitium, some others are actually crossing the cell walls into their adjoining cells. This process keeps increasing as the temperature stays elevated, and eventually when they cool, we get something like an egg frying phenomena, right? Protein denaturation is just a fancy way of saying the protein has now cooled and folded in all sorts of odd ways, and there is no way to get the normal structure back. It's a point of no return, which is exactly like an egg frying. If you've heated eggs, do you ever get the liquid albumin back? No, you don't. It's never going to be runny again. It's always going to be in a solid state. Similarly, at 60 to 90 degrees, your cells once have undergone protein denaturation. There's essentially no coming back from that, and the structure is permanently altered. Say we increase the temperature a little further at 100 degrees Celsius. Well, the fluid within the cells reaches its boiling point, and then suddenly you get vaporization. This is particularly important to cut tissues because it is this sudden burst of energy as a result of vapor escaping cells that we get a cutting effect within our tissues. Say you're being a little greedy and you want to increase temperatures even further, right? You increase temperatures to say 200 degrees Celsius. Well, at this point, you're looking at carbonization. Whatever residual carbohydrates there are within these cells, they are going to be burnt, undergo some form of caramelization. If any one of you guys has ever had the misfortune of trying to make tea or coffee and forgotten to add milk, this is essentially what you get within the vessel because you've just added sugar and some other coffee or tea, right? The sugar basically burns, it becomes extremely sticky, essentially forming an eschar of sorts, which is exactly what happens within tissues as well. When voltages are very high, temperatures become very high, these sugars burn and they lead to the formation of an extremely sticky layer. And that is the reason why we get that black deposit at the end of our electrosurgical energy devices as well. So once again, radio frequency that we are talking about is in the 5 lakh hertz range, which is right here close to AM radio. The reason why I'm reminding you of that is because you need to remember that the frequency of electricity within our wall sockets is 60 hertz and the voltage is 240. This device, the electrosurgical unit or the generator as we so lovingly call it, does a few very important functions. The first of which is it changes the frequency of the alternating current from 60 hertz to 5 lakh hertz. That's a massive jump. Additionally, it changes the voltage from 240 volts to close to 3000 volts. Think about it. When you go down to your building mainframe and check out the voltage that has been printed, it's usually around 400-ish, and there is a big skull and crossbones that is present over there. Imagine if you had that sort of a danger warning attached on top of every cautery machine. Actually, you know what? That is a great idea. At least that way surgeons will start paying more attention to their cautery devices. But 3000 volts is a massive voltage, correct? Just think about that the next time you're firing off your cauteries. And this device also ends up changing the nature of the alternating current output by changing the duty cycle. So this is a very common cut and coag that we keep talking about. So the cut has the usual color coding of yellow. There is a coag that is color coded as blue. Within cut, you have a choice of several different settings. Most commonly, it is between a pure cut and a blend mode. And beyond that, you have these numbers which are put up. So my favorite question to new residents is, what exactly are these numbers? Most of them just give me a blank stare. Some of them go and say, sir, it is the percentage of power that the device is capable of that we are shooting. So I said, okay, in that case, shouldn't be using it at 100, use it at maximum power. That usually confuses them even further. But what these numbers mean, when you set, say, the cautery machine at 30 and you select pure mode, is the power that is eventually being delivered to the patient in watts. So power is a function of both voltage as well as current. I won't get deep into physics. Let's specifically talk about the cut mode at 30 watt setting. Remember, it's an alternating current. So if I plot a graph of the way the current is moving and what sort of voltage is being delivered, this is the curve that you're going to be sitting and getting. It's a continuous waveform, low voltage current when set on pure cut mode. The duty cycle is at 100%, which means that while the alternating current is going from positive to negative, it's changing its direction and it is at zero ever so often, the current never stops. So delivery of the current is going to be near constant, so the duty cycle stays at 100%. So remember, the power delivery is a function of voltage into current. So I've plotted the voltage over here on the y-axis, and on the x-axis, we are talking about current as a function of time. So the total amount of energy that is being delivered. Now let's see what happens when you increase the power. So I'm going in and I'm changing the wattage to 60. All right. Just have a look at how this curve has changed. So we are still at a duty cycle of 100%, which means the total time duration for which the current is actually flowing through the system has stayed constant. So think about this. If P has increased to 2 times, we went from 30 to 60. Then I has stayed the same because we are at 100% over here. Then the thing that has to increase in proportion is the voltage, which is exactly what you see, that the current has actually developed higher peaks on either side of the baseline. But you know what, I am actually quite scared of keeping the cautery setting at 60. So let me just come back down to 30 watts for the time being. So I get again this low voltage continuous waveform current. I'm going to keep repeating that ad nauseum. All right. So again, power is a function of voltage and current. So because it's a product, essentially power can be shown as the shaded area as area under the curve. So that's the total power delivery in red that you're sitting and seeing on screen. Now say I'm sitting and shifting the entire cautery to coagulation mode. I'm hitting this up to the same power setting of 30 watts. At this point in time, this is a sort of waveform that I am sitting and looking at. So these are very high peaks, but notice that the current has actually shut off for a long period in the middle. So this coagulating current, I'm going to say coagulating with air quotes, it has a duty cycle of 6%. That's a very low duty cycle compared to the cut current, right? So if I plot the power delivery, the area under the curve, this is what it's going to sit and look like right now. Once again, it has to compensate for this time off by significantly increasing the voltage when the current is on. Now let's compare these two forms of power delivery. We have cut and coag. Now keeping the power setting the same at 30 watts, it could be any figure that you choose. Notice that the area under the curve on the two sides has to remain constant. The two main differences are that on the coagulating side, the voltage is much higher and the duty cycle is lower, which means the current is not delivered to the tissues for long periods. The power delivery has stayed constant, but essentially how this power is delivered to the tissues has undergone significant change. And this is the change that I'm sitting and talking about. This is me using a hook diathermy within a TAPP for an inguinal hernia, this entire space is being dissected with cutting current. Now see, at one point I find some ooze from close to the pubis and I'm immediately going and firing a coagulating current on spray mode. And you'll notice that there is no eschar anywhere within the surgical field except for the area where I am sitting and applying this coagulating current. There's a reason for that. The coagulating current has an extremely high voltage, and that voltage lands up increasing the tissue temperatures to 200 degrees and beyond. That is the point that produces carbonization. In comparison, wherever I'm sitting and using cut, the low voltage continuous waveform current, low voltage being the keyword, just gets the tissue temperatures up to around 100 degrees vaporization. So tissues are getting divided, the blood vessels are getting nicely coagulated, and I have a clean surgical field except for that one filthy part where I landed up using a coagulating current, correct? Try this out, or rather experience this in your ORs the next time around. When you use a cutting current, you have less eschar even on your cautery pencils. Guys, I keep saying cautery interchangeably because that is common parlance, but the correct terminology is going to be electrosurgical energy devices. Please don't crucify me for using cautery as a word ever so often. All right. So let's go back to the ESU. There's also a blend mode. What exactly is this? Now, there is no color coding for the blend current. I'm just going to use pink right now for the heck of it. All right. I'm setting the ESU again to 30 watts and using a blend mode. And this is the sort of current that you're sitting and seeing right now. So it's definitely not a continuous current, but the duty cycle has to be higher than what we see in a coagulating current, right? On an average, the blend mode is going to have a duty cycle of 50%, which means the current stays on for 50% of the time and off for 50% of the time. And this is the area under the curve, which conforms to 30 watts in this particular case. So duty cycle in blend modes is extremely variable. In most machines that have different blend modes designated, the first one will have a duty cycle of 33%, second one will be on an average 50%, and the third one will be close to 80%. Now again, notice that these are all approximations and the actual figures may vary depending upon which ESU or which company you eventually land up using. So I can't be sure what exactly is happening in your ESU. You're going to have to look at the manual or go through all of the settings yourself. Usually the blend mode duty cycles are not shown on the displays of these ESUs and you have to go back to their manuals. But some important questions about the blend mode. Is it necessary and is it a mix of cut and coag? The answer is a very firm no. I'm going to put up all the three curves on your screen right now. So cut, once again, is a low voltage continuous current. Coag is a high voltage low duty cycle current, so it's intermittent with a duty cycle of 6%, and this is where blend is at right now. Once again guys, the power delivery has been the same across all of these currents, right? The area under the curve for cut, blend and coag in total has been the same, but look at the voltage differences. Because coag has to work for a shorter period of time, it has to have a higher voltage delivery to the tissues to compensate for that low duty cycle. And that is responsible for most of the problems that I'm going to be talking about in subsequent slides. So the blend mode is somewhere in the middle of all of this, but it does not give you the best of both worlds. For example, I showed you guys that surgical video of me going through the tissues with a cutting current. Tissues get vaporized very easily. Yeah, that's a feature of the cut current. Coagulating current is extremely good for coagulating raw areas, like say a liver bed or when you don't have very distinct bleeders. Does the blend mode adequately achieve both of those? Not really. So it doesn't serve both functions. I would rather say you identify the problem in your surgical field properly and use either cut or coag depending upon what the solution calls for. Don't be an imbecile who uses a blend mode everywhere. That's just not going to do you any favors, and neither is it going to do the patient any favors. The second thing, so I have used the pink color coding for the blend mode in my presentation, but which pedal do you eventually have to press for the blend mode? The answer is the yellow pedal. Let's have a look at the ESU again. So the ESU will have a pure mode on the cut side and a blend mode on the cut side once again. So hold on a minute. If we are using alternating current for all of these different modes, shouldn't our patients actually be electrocuted like this? Something like electroconvulsive therapy for our cases, right? Yes and no. Alternating current should technically electrocute you. So for example, if you stick your fingers into your wall socket, which I am not advising you do, you will get tonic-clonic seizures at that given point in time. You will undergo this classic electrocution. But notice that electrosurgical energy that we'll end up using is at 5 lakh hertz. And at such a high frequency, the the sodium potassium channels and the calcium channels on the cell walls, they just don't have enough time to open or close. The moment the current has started, before the channels open, it suddenly reverses direction. So the threshold is never reached for these channels to open, as a result of which the muscles never twitch. But then you're going to say, hold on a minute. You're saying the patients should not have seizures and the muscles should not twitch, but I have definitely seen muscle twitch when I use the cautery pen. Yeah, you are also correct over there. And the explanation for that is that when you use high voltage current, particularly the coagulating current, when you're using it absolutely next to muscle with a high density of these depolarizing channels on their cell walls, so essentially muscle rather than nerves or any other tissue, there are low frequency non-alternating or direct current loops that get set up in the vicinity. That is a feature of the interface of these biological tissues with the high frequency alternating current that we are sitting and using. Honestly, I don't understand the physics of it all completely. All I know is that these local loops within the tissues are responsible for the muscle to twitch. The higher the voltage, the worse the twitch is going to be. The closer you are to muscles, the worse the twitch is going to be. It is definitely not a function of how deep a plane of anesthesia the patient is in. If you're seeing a lot of muscle twitch, maybe you're in the wrong plane, or maybe you're doing it intentionally, but just keep that in mind. Maybe you want to switch your mode to a cut mode so that you don't get as much twitching. So let's start talking about monopolar current. So we all have 2 wire attachments on the ESUs. One is for the cautery pencil and the other is for the grounding pad or the dispersive electrode, which is present on the patient. At the outset, let me just go and say that calling this a grounding pad is not correct, because a grounding pad would mean the pad directly connects into the ground. So this used to be a feature of very old electrosurgical units early on, like within the first 20-25 years. But note that there was no control over how much energy would actually be flowing into the ground. So the amount of energy delivered to patient tissues was very, very, inconsistent or unpredictable. As a result of which, we now have circuits where there is a dispersive electrode that connects directly into the electrosurgical unit. It does not get grounded, all right? That being said, the entire ESU by means of its power cord gets grounded, but not the patient. The patient is interposed between this cautery pen and the dispersive electrode, which is usually placed on the lower half of the body, and current flows between these two poles to finish off an isolated loop. So remember, there is no grounding pad. The circuit is entirely isolated, which consists of the ESU, the cautery pen, the patient, the dispersive electrode, with the current then finally getting completed at the ESU again. The bipolar devices that we'll end up using have both of these wires essentially going into the same device. Now you may be arguing that, no doc, I've seen a single wire for bipolar devices. Yeah, it's a single wire, but within it contains 2 different wires, okay? Essentially both the active and the dispersive electrode bits go into the same energy device. And when you apply bipolar devices to patients, the electricity flows only through the small amount of tissue that is placed within the jaws of the bipolar device. Now, is this going to work, this arrangement that you see on screen? The answer is of course not, right? The circuit has not been completed. So it's not going to work. What you need is a dispersive electrode for the circuit to be complete. Now remember, all radio frequency energy is bipolar. Okay. For example, even in the monopolar diagram that you're seeing, there's one pole here, another pole there. There are always going to be two electrodes involved. I think the definition of monopolar and bipolar should be changed to how many poles are in your hand. So for example, if I'm using a monopolar cautery pencil, that's because only one electrode is within the device which is in my hand. Whereas if I'm using, say, let me go back, a bipolar device, then both electrodes are in my hand at this point in time, right? So that's bipolar for you. All right. So this is the dispersive electrode. And these are by and large the two types of dispersive electrodes that you're going to be seeing. You will either see a continuous plate which is there on the left side of your screen, or you'll have these split plate configurations. The split plate configuration is actually a safety mechanism. Say you have a dispersive electrode which has not been applied evenly to the patient. The ESU determines that the pad is now asymmetrically applied, which means the amount of current flowing between these two pads is not coming in evenly. So it automatically cuts off the power supply and it asks you to check how the dispersive electrode has been applied to the patient body. So if you ask me which one of these two is desirable, I would definitely choose the split pad electrode on the right of your screen. So once again, this is a bipolar device that we have. Sometimes bipolar devices don't land up working. Now, don't worry, they will land up working when you apply the dispersive electrode. Now, you may be thinking this is going against the principles of everything that I've spoken so far, because at this point in time, there are three different electrodes, right? 1, 2, and 3 on your screen right now. You're correct. But this is a safety mechanism that has actually come in. See, understand that at most surgeries, both monopolar and bipolar devices are going to be connected, are going to be in the surgical field. Sometimes you have monopolar devices just lie on the patient's body. Okay, this is one image and this is another image. So imagine you're trying to fire the bipolar device, but you accidentally press the wrong pedal. Well, in that situation, you're going to have all sorts of misfires. So you're also sometimes not attached the grounding electrode properly, thinking that you've just going to be performing bipolar or going to be using bipolar energy in that particular patient, and that can increase the risk of electrothermal energy for the patient. So in most of these situations, the newer ESUs will not fire even bipolar unless the grounding pad has been attached. This is a new safety feature which may or may not be there in your ESU. You're going to have to check that out. But these images are going to tell you what is not supposed to be done in the OR. Please don't keep the cautery pens on the patient body when they're not being used. Most of these pencils come with a plastic non-conductive little basket that once again is not kept on the patient body, mind you. It's actually hung from one of the scrub trays on the side from the sterile trolleys. So we're going to take a moment to talk about current density right now and its implications in surgery. This is an active electrode, which is the cautery pen in my hand, and this is of course the dispersive electrode. Now the question really is, if this is an isolated circuit, then the amount of electricity that's flowing through this wire is the same that is flowing through this pen, is the same that is flowing through this electrode and this wire, correct? Then why is it that I'm only seeing an effect at the end of my cautery pen? That's a very important question. What happens is when you're applying the pencil to the soft tissues, there is an extremely high current density that comes in because the tip of your cautery pen is extremely small. That entire current then spreads across the soft tissues and goes to an extremely large, wide dispersive electrode. So the current density at the dispersive electrode is much lower, even though the quantity of energy which is going across remains the same. Now, say for whatever reason, I have not attached my dispersive electrode that well and it's coming off on one side. Well, you can see the energy delivery staying the same. The current density on the dispersive electrode side is actually increasing, right? This is seeming a little unsafe. So let's make it even more unsafe right now and make it even a narrower attachment to the patient body. And you can see at this point, the current density has gotten extremely high on the dispersive electrode side. So much so that it's no longer a dispersive electrode, it's just an electrode. This is the point at which you'll end up getting a lot of thermal injury in an area far away from your surgical field. Another common issue with the dispersive electrode is the orientation in which it is placed on the patient. Sometimes you will have it placed obliquely, as a result of which a corner is towards the side that you're sitting and operating. So most of the energy that returns by means of the dispersive electrode gets concentrated at this leading corner that is present over here. And because most of the electrical energy is coming in by path of least resistance at this corner, you will end up developing a small burn at this area. The correct way of sitting in applying a dispersive electrode is with a long flat edge towards the area of interest which is being operated upon. So you get a good dispersion of the energy on this side, and you get low current density and lesser likelihood of any burns. Remember to always apply the dispersive electrodes over a well vascularized muscular area with a long edge towards the operative side. So I would suggest applying these over the legs rather than the buttocks sometimes, because some obese patients are just going to have a lot of fat in that area, and fat, we all know, does not conduct electricity very well. Always avoid bony prominences, previously scarred tissues. So for example, if you have a patient who's undergone varicose vein surgery on the right leg and you want to apply a dispersive electrode, apply it on the left leg instead. Why do you want to use any scarred leg? Also check if the patient has had any metal implants or pacemakers. You don't want the pacemaker to be coming in the way of your energy use. So you need to figure out a way to keep your dispersive electrode as far away from that area as possible. Try to avoid areas that have excessive hair, or if possible, shave and prepare one of the legs to apply the dispersive electrode. Avoid pressure points under all circumstances. Don't apply dispersive electrodes to limbs that already have a neurovascular compromise, because these guys will have low muscle mass in these limbs. That's one. Number two, when damage does occur, or rather if damage occurs, it's going to be more problematic to solve in the long term. And the last bit is very, very relevant in pediatric cases. Do not apply the dispersive electrode at any place where fluids may land up pooling, because that pooling, especially if it's spirit, can be the point at which a fire may begin and a patient may get badly burned. Additionally, the fluid acts as a low resistance conductor of electricity, and patients can land up having an odd burn even beyond the dispersive electrode. I'm going to take a moment to talk about physics and capacitors, because we have a couple of interesting topics to discuss within the space. A capacitor is nothing but a device that has a non-conducting separation layer within it. When you apply a capacitor within a circuit, you can see a battery has been applied over here. What happens as a result of this voltage application is that the ions within that circuit land up going to one end of the capacitor or the other. So you can see there is a lot of negative charge that is accumulated on this side, and there is positive charge that has gotten accumulated on this side. When you say complete the circuit over here and even take away the battery, this capacitor can discharge over a period of time, and that energy gets stored within these capacitor devices. Capacitors are extremely common in electrical devices for that reason. If you've used, say, TVs or I'm going to pause this. So if you have ever switched off the mains to a TV or some other electronics, you'll realize that the indicator light on these devices lands up going off quite a few seconds after you have switched off the power. That is because the capacitors within these circuits are discharging the energy that was stored within them. The capacitive technologies that I'm going to be talking about actually applies to the dispersive electrode that you're seeing on screen. I'm not a salesperson for this device, but it does have a lot of neat safety features that I'm going to be talking about right now. So in most situations, you have an isolated circuit that is generated between the ESU and the patients, and the dispersive electrode is applied with the help of an adhesive pad. You can see the entire circuit on screen has gotten completed, and there is flow of electrons all across the patient. from one end, that's one pole, that's a cautery pen, to the other end, which is the dispersive electrode. If you have problems at the dispersive electrode, such as say a poor attachment, or you have surrounding areas like tattoos and implants that land up having low resistance, the current preferentially flows through those areas, and that is a recipe for setting up burns. Instead, you have these patient side pads, which are large capacitors. So these pads are created with an insulating material put on the patient side as well as on the OT table side, with a conductive mesh within the center. It is within this mesh that a lot of the electrical conduction eventually lands up happening. When you apply voltage across the patient at this point in time, because there is an insulating pad, technically there is no flow of electrons that occurs from the cautery pen to this dispersive electrode that you're seeing on screen. Instead, the patient and this pad land up behaving like a capacitor, where they just store charge. And the alternating nature of the voltage means that the charge is stored and then reversed extremely rapidly. It is this shift in the amount of charge which is present on the patient side that eventually produces the oscillation of ions, the heat, and this conversion of energy. Now, remember, if the amount of contact reduces between these two areas, automatically the capacitance to hold ions reduces. So there is a lesser likelihood that great energy will be delivered even when the area is narrowed. So the problems of partial application of a dispersive pad are not applicable to a capacitive electrode. These pads are extremely large, about 3 by 2 feet in size. That's feet, not inches. As a result of which, these can be placed under the entire patient on the OT table. And as I said, the capacitance or rather the amount of energy that can be delivered is a direct function of how much area is in contact. As the amount of area keeps reducing, the amount of energy that can be delivered to the tissues will keep on reducing. In contrast with a standard dispersive electrode, where there's actual flow of electrons across within the circuit, where if you reduce the amount of contact, then you have a higher current density with a higher chance of injury. Where is this pad particularly useful? It's amazingly useful in pediatric patients, where the entire child can be placed upon the pad. Note that pediatric cases, otherwise surgeons usually land up using almost exclusively bipolar. But bipolar devices are by default not as flexible or don't allow for as much, manipulation of tissues as monopolar devices. Monopolar devices can be changed to get several different tissue effects. That's not the case with bipolar. So this is a very neat and safe way of using monopolar energy in a small patient. What are the other strategies that can be applied for kids? The first is that you can, as I said, almost exclusively use bipolar energy. You should always use an extremely low power setting. There are a few pediatric surgeons I know of that never land up increasing the power setting more than 8 or 10 for the very small kids that they're sitting and operating upon. The other thing I would like to say is use water retardant drapes. Which don't allow pooling. This is a particular problem for small kids because even a small amount of pooling can actually make them susceptible to cautery related injuries on the dispersive electrode side. So let's talk about how thermal damage, or I should say the cautery effect, actually lands up happening in the patients. What are the determining parameters? Well, thermal damage is directly related to the square of the current density that is being produced. Note that this is the only factor on screen that is raised to the power of 2, which means small changes in current density will produce exponential changes in the amount of thermal energy that is being delivered to the tissues. When you apply your cautery pens extremely straight with a small area coming in contact with tissues, thermal energy delivery is high because current density is extremely high. Say if I apply the same energy with the cautery pencil being kept flat with the amount of area in contact with the tissues increasing, current density becomes low. So I don't get as much cutting effect as I saw in the earlier diagram. Now I'm getting more protein denaturation, which is vague and happening over a large surface area. Once again, if you're holding it with a very small amount of contact, or rather I would say near contact of the active electrode, there is something very interesting that lands up happening. If you apply a cutting current, again a low waveform continuous current, there is arcing of the current across air. So it's near contact, it's not actual contact. As a result of the arcing of current, there is a sudden delivery of energy to the tissues that usually reaches just over 100 degrees Celsius, which produces vaporization of the cells. This vaporization not only produces steam, but also releases a large amount of ions within the gas around the operative area. This plasma cloud of vaporized ions conducts electricity in turn, and that lands up causing a very high current density at the tissue site. So you're basically causing current arcing, but you're not doing it using the high voltage current present in a coag mode. Remember, I'm talking about a safe cut current which is present on screen. In a coagulating current with extremely high voltage, you will find sparking very, very easily. I'm going to show you one example in just a bit. That's because also remember that the coagulating current has an inbuilt spray mode. The spray mode is one of the highest voltage settings that you will have within the coagulating current that causes absolute sparking across tissues. You want the tissues to have some sparking, but you want to do it in a low voltage manner that maintains current density. So this, using the cutting current, is a very targeted application of energy to a narrow area. This is one example of how you can alter current density. So I'm taking away all of these tissues with my hook, and you can see there's barely any eschar all over the place. Now there's a fascia that needs to be divided. If I try to take it with the inner aspect of the hook, my current density is not going to be high. Instead, what I'll end up doing is I'll end up using the shoulder of the hook at a single point to divide that tissue very, very easily. Once again, I'm going to play it for you guys. Note that all of the other tissues land up taking significant amount of time and traction to pull and apply cutting current to. And because it's loose fibrofatty tissue, it gets divided eventually, but again without any eschar. The properly formed fascia has to be divided. I reduce the amount of contact with the hook by using the shoulder, and you can see this fascia gets divided very, very quickly and very easily. The other important factor that I'm going to be talking about is resistance within the tissues. You have to increase resistance the correct way. So some of the ways to sit and do that is compress tissues to remove all of the interstitial fluid. If there is less fluid within the tissues, the resistance is going to be high, the thermal energy that is generated is going to be high. Suction out the surgical field to remove all conductive blood. This has the added effect, flowing blood acts as a heat sink. It actually cools the entire surgical field. So you need to get rid of the heat sink effect by clamping any vessel that needs to be divided and by suctioning out all of the blood which is present over there. Compress the arteries to empty out the lumen and which occludes it. When you are getting both the sides of the intima to get compressed and apposed against each other, the technical term for that is coaptation. So you need to coapt these vessels to be able to get rid of the heat sink effect, as I mentioned, and to be able to adequately denature the intima as well. That gives you a good seal. And finally, something that is very understated is applying resistance to the tissues, applying a stretch to the tissues to increase their resistance to improve the thermal energy delivery. This is a video of a lap cholecystectomy with just a few adhesions. You can see all of these adhesions are going to be taken down with the tissues kept at a significant amount of stretch, and a lot of this division is happening only with a continuous low waveform current, which is the reason why you're not seeing any eschar formed within the tissues. You may see tissues getting denatured and whitened out, but you're not seeing any charring or carbonization anywhere. At every given point in time, the tissues are being placed under stretch so that the energy delivery is efficient and tissues get divided extremely well. The other important determinant of thermal damage to the tissues is going to be time. Now, this is a no-brainer, right? The longer amount of time you keep the pedal pressed, the more amount of energy is going to be delivered to the tissue and more likely the chance of iatrogenic injury. This is particularly true of the coagulating current, which is a high voltage current that has the greatest amount of, the propensity to do damage to the patient tissues. So whenever you can, use short bursts of energy, use the correct current for, or rather the correct mode for the task at hand. You can't use the same current all throughout. It's just not a smart way of operating. Now, voltage is equal to current and resistance. This was a formula that may have been taught in the 7th or 8th standard to all of us. So if I is a current, I'm going to take it as a proxy for the amount of power that is delivered to the tissues. Say we keep I constant throughout, the amount of power that has to be delivered, then voltage is going to be directly proportional to the amount of resistance within the circuit, correct? So now see what's happening. When you use a monopolar energy device, you have so much of the patient tissues between the two electrodes. Because of the high amount of tissue, the resistance is also going to be high. In comparison, when you're using bipolar energy, for the same power delivery, the amount of tissue that has to be grasped within the two electrodes is small, so it's a lower resistance. Eventually, monopolar energy has more tissue between electrodes, higher resistance, therefore higher voltages are required. In stark contrast, for bipolar devices, there's a lower resistance, so a lower voltage for the same amount of power delivery. And this is the reason why bipolar devices are inherently safer than monopolar devices. Think back to that slide about energy use in pediatric cases. The first thing I mentioned is the use of bipolar energy is preferred. It's for this very reason. Because the voltages are kept low, the amount of iatrogenic injury that can occur, even apart from the dispersive electrode issues that we have gone and discussed, is going to be much lower. So bipolar devices in a nutshell have low voltage, low risk of collateral damage, and the problems with dispersive electrodes are completely omitted, right? You are not going to be worried about patient pacemakers and metal prostheses and causing these sort of distant iatrogenic injuries to the patient, because all of the magic in bipolar devices is going to be happening within the jaws of that device. So there's no risk of distant damage. It is perfect for use in neurosurgery because they are working in a surgical field that is sensitive for electro energy. In wet surgical fields, again, very, very useful. If you apply monopolar energy to a wet field with a lot of fluid within the cavity, the fluid lands up conducting energy across, the current density is lower and you don't land up getting the desired thermal effect. In contrast, you can put in a bipolar device in a completely wet field, but eventually the amount of tissue or fluid contained within the jaws is the only part of that surgical field which is going to be involved within that circuit. So energy delivery is still going to be as close to as what you desire as possible. And the last bit is it's perfect for use in pediatric cases. Patients, we've already covered that. So the bipolar devices are not just the simple bipolar devices like the one you see in the center over there. There are also these pretty complex looking devices on two sides, right? What are those exactly about? Additionally, most of these vessel sealers, the bipolar devices which are present on the right of your screen, have an extremely wide jaw, which is in stark contrast with these standard open bipolar forceps. And additionally, there is also a groove within the center. Let's explore that right now. When you use bipolar energy across a vessel, this is essentially what you're doing. You compress the vessel between the two jaws. Remember, this is called coaptation. So the intima of the two sides is now opposed to each other, and the heat sink effect of flowing blood has gone away. When you apply energy, the cell walls, as you can see on your left, they've become leaky. The proteins are coming out across the cell walls. At the end, the protein cools across the cell walls. The intima of the two sides actually gets fused to each other, and this leads to the production of a pretty stable seal that should not open up even when the device is opened. So the seal stays constant and the blood vessel stays shut. So wait a second, there is only one pedal for bipolar, correct? So always there'll be a cut and coag pedal for monopolar, but for bipolar there is only one. There's a reason for that, because there's only one type of current that flows in bipolar devices, and that is this: a low voltage continuous waveform current with a duty cycle of 100%. So note that a cutting current is flowing through a bipolar device, but the color of the pedal is blue. Doesn't make sense, right? It's like a facepalm moment over there. Now, this is a great opportunity for me to cover a few things. That electrosurgical energy devices have undergone great standardization over the past few years. The major injuries that used to occur from the use of electrosurgical energy in the first few decades after its invention was that the devices were not standardized and the effects that we were getting out of using different generators was not consistent. So surgeons were not sure what exactly is going to happen when they'll end up firing the device. Even the same device on the same day may end up giving different outcomes on two different patients, different variables, different error. But when the push eventually came to standardize these devices, I think people in a very foolhardy manner landed up color coding them and calling especially the two pedals cut and coag. I want to point something out. You can achieve vessel coagulation with a cutting current. Isn't that what is exactly happening on a bipolar device anyways? So then what is the purpose of a coagulating current then? Does it coagulate all of the vessels in the field? Now this is the reason why so many people end up using the blue pedal excessively at the time of surgery, which I have kept on mentioning over the course of this presentation, is a high voltage, unsafe current with high eschar formation and a high chance of iatrogenic injury. People still end up using it more just because it is called the coagulating current. It's a very foolish sort of mistake that has happened at the time of standardization, but it's not something that we can land up correcting. So in my OR, I don't say shout cut and coag. If I'm training someone, I just say yellow pedal or blue pedal or continuous intermittent duty cycles, because that's essentially what they are, right? It's not that the coagulating current can't cut and the cutting current can't coagulate. So we need to get over this in our minds and truly understand the basics or the fundamental principles of these energy devices to be able to use them with some amount of confidence in the OR. So again, with bipolar devices, you'll end up forming an extremely effective seal by using a low voltage continuous waveform current that you see on screen. If we land up using a coagulating current for whatever reason on a bipolar device, okay, this is what is going to happen. Because of the high voltage nature, there are going to be several small little eschars, like the video that I showed you, going to form all across the vessel. Now, these caramelized eschars are by default going to be sticky. So when you open up the two prongs of the device, the vessel is going to essentially stick to them and it's going to prop back open. The other thing I want you guys to note is that whenever eschar forms, it immediately stops conducting electricity. So if you have a surface eschar on the outside of the vessel, you never get energy delivery to the intima that stays relatively untouched. Think back to the diagram that I showed you earlier. It was the apposition of the intima and energy delivery across it that is responsible for forming an effective seal. So when you're using a coagulating current, you get none of that. In fact, you're complicating the matter further by making the vessel extra sticky. And as soon as you open it, everything is going to come undone and is going to bleed even more. So while we are on the topic, shouldn't we be using cutting current even when using monopolar energy? There are so many times where you'll just grab a vessel in the operating field and ask somebody to touch your forceps, right? Which is exactly what is happening within the image over here. Yeah, you are absolutely correct. So the principles of electrosurgical energy are going to stay the same for monopolar devices too. So whenever you have grabbed a vessel within a forceps, you want to touch with a cautery pen, but always fire the yellow pedal for an effective seal. When you do this, eventual sealing and steam formation from the caught area may take a little longer. You need to hold your horses and be patient. I promise you, the nature of the seal that is so formed is going to be much stronger as compared to if you had used the blue petal instead. So I'm going to again come back to dedicated bipolar devices and vessel sealers. Now, an important thing that happens with these vessel sealers is that when you press the activating button, there are a bunch of different beeps that come out, and even say it beeps constantly and then eventually has a very strong change in beep and then it stops. What exactly is happening over there? Well, when you're firing, you've got tissues within these devices, right? These are two dedicated vessel sealers that you're seeing on screen. One is open and the other is laparoscopic. When you catch tissues within these devices and you press the firing button at that point in time, in a split second, it sends a small current across the system and it gauges the total resistance of the tissues that you have grasped. It stores it in its memory. Within the electrosurgical units, there are predefined algorithms that determine how much of a resistance change is meant to occur for vessels to get sealed within the tissue. Remember, when you're denaturing proteins within a surgical field, they become poor conductors of electricity, which means the resistance increases. So when you're effectively sealing vessels, essentially the resistance of whatever tissues you've grasped should increase. These devices will constantly keep checking the resistance to the flow of electricity within the tissues, and when this change in resistance reaches a preset value, they stop firing current. So when we talk about dedicated vessel sealing devices, there is a pretty complex a computational algorithm which is utilized to figure out when exactly an effective vessel seal has formed. This is in stark contrast to the plain Jane bipolar forceps that we use in surgery, where essentially I could keep the bipolar pedal pressed all day and it will keep firing energy across the tissues, not giving a damn as to whether a seal has formed or whether tissues are getting excessively charred. These devices, because they are checking this change in resistance, have several inbuilt safety mechanisms. What exactly are they? The first thing is there is a temperature sensor. They want to get the temperature up to 60 degrees Celsius. This, remember, once again, is the point at which instantaneous cell death occurs. So you don't have to wait 5 minutes for cell death. Okay, you can't keep applying energy for that long. They want the temperature get to around 60 to 80 degrees Celsius. So when it reaches that preset temperature, but say the change in resistance has not reached where it needs to be, it shuts off the energy, allows the tissues to cool, and once they are cool, it refires them. All of this happens within split seconds. So this is one of my cases from a lap left nephrectomy. You can see I'm using a dedicated vessel sealer on the left renal vein, lying directly on top of the aorta. So the peculiar point that I want you guys to note is once I start firing the energy, the steam that you see coming out from the area actually has a pulsatile nature. Even the bubbles start and stop intermittently, which means that despite me keeping the device button pressed at all times, the device on my behalf is shutting the energy, or rather is turning the energy on and off, ensuring that the temperature within the tissues does not rise beyond a certain level. It doesn't want the tissues to get vaporized. It wants the intima to become extremely sticky and adhere to the opposite side, have good cross bonding between the protein molecules to give you an effective vessel seal. When you're using any of these bipolar devices, be it a dedicated vessel sealer or a plain bipolar device, when you press a pedal, essentially what happens is that the electricity flows from one jaw to another jaw, and you'll end up having a denatured soft tissue component held between these two jaws. If you land up firing bipolar energy again, at this point what lands up happening is the tissue resistance within the jaws that is caught has gone up significantly because you've already denatured everything. So the path of least resistance actually is around in the soft tissue that you have not essentially caught between the jaws. This is termed the mushroom effect. So this you need to keep in mind. Don't repeatedly keep applying energy to the same area. If it stops bleeding, you need to stop applying energy. It's not going to give you any added sense of security. You'll be having more lateral thermal injury if you keep firing bipolar energy in the same area over and over again. I'm going to be talking about a few common mistakes with bipolar devices that I'm sure all of you guys can benefit from. The first one is not coapting the vessel. So just keeping the bipolar device open. This could be a dedicated vessel sealer or it could be a plain bipolar device. Now, as a result of not coapting, what's essentially going to end up happening is the blood which is flowing within is going to act as a heat sink. The second thing is that the intima does not get apposed to the intima on the opposite side. So you don't get those cross bonds that I have been sitting and talking about. The media may get charred a little bit, but the lumen of the vessel relatively stays patent, so you're going to have continuous bleeding from that area. What you want to land up doing is this. Press the bipolar device down, coapt the vessel, fire energy, bringing about an effective seal so that when you finally open the bipolar device, the tissue stays shut and you don't have any bleeding from the cut end. The mistake that people end up making sometimes is reapplying bipolar energy over and over again. Now what's going to happen is, say you've already had an effective seal and you reapply energy at the same spot. It's a change in resistance that the device is going to pick up. It's not going to know that you have already buzzed this area earlier. It's going to want to increase the resistance in tissues even further. As a result of which, the excess energy delivery will now land up charring and carbonizing these tissues, which is exactly what these devices are designed not to. So if you keep applying bipolar energy to same area over and over again, it is definitely possible to form an eschar, carbonize the area. When you land up opening the jaws right now, you will end up avulsing the vessel slightly because remember, these caramelized eschars are very, very sticky. Pro tip, when you are ever using bipolar devices, especially around an important vessel, and you realize that the device is not coming off very easily and you're scared that it's going to avulse the vessel, what you should be doing is putting a lot of normal saline within the area, marginally closing the bipolar device and then firing the device for a short burst. It's going to vaporize the normal saline which has entered the surgical field, and the steam bubbles that are created are going to help dislodge that jaw from wherever it has gotten stuck, and that's going to help you to release the bipolar device out from wherever you're stuck at that point. The other mistake that people keep on making is once they have sealed a vessel, they go very far away and they'll end up trying to create another seal. What's going to happen is you get two kind of okay seals with an intervening area that is completely unsealed, that is also not going to tolerate any high pressures. So this is not an effective way of going about it. What you want to do is, once you have created a nice seal, you want to move slightly away from that area, having an overlap of 30 to 50% and then refiring the bipolar device there. So you want this around 30-50% overlap to improve the strength of your seal, but not jeopardizing the tissues that you're trying to achieve hemostasis in. All of these dedicated bipolar devices I mentioned earlier have broad jaws, much broader than the standard bipolar devices. The dedicated vessel sealers also have this little groove. You can see in all of them, there's going to be a groove on the inside. What exactly is the function of the groove? Now, this is a great paradox that I need you guys to understand. A cutting current on monopolar cuts because it vaporizes everything. But a cutting current on bipolar coagulates. Correct? We covered this right now. The corollary is that a cutting current on monopolar cuts, but a cutting current on bipolar does not cut. I know that sounds like a lot, but bear with me. When you're sitting and using a dedicated vessel sealer across devices, you never land up dividing tissues. The reason for that is very straightforward. It's that current density has changed as a result of the amount of tissue which is being grasped. When you land up using a cutting current on a monopolar device, you have an extremely high current density at the tip of the device, which lands up giving you the cutting effect. But when you're using the same form of cutting current on a bipolar device, you're doing it across a tissue bridge. And because there is a tissue bridge, the current is spread across that entire area that lands up forming a good intimal seal, but you cannot achieve vaporization because of the sheer amount of tissue that is being grasped. So for bipolar energy, dedicated vessel sealers in bipolar energy devices, that groove is actually accommodating a blade that you fire by means of a separate little trigger. Once an effective seal has been formed, the tone on the machine has changed, you fire the blade to cut the tissues across. Let's take a step back to monopolar energy. always electricity is going to follow the path of least resistance. And this is what I mean by it. When you're applying monopolar energy onto a tissue surface, the electricity is going to spread across and go to all parts of the dispersive electrode. And you can see in this diagram that the current density is going to be highest at the point at which the cautery pen is touching the tissues, and the current density becomes lesser and lesser as you're sitting and getting close to the dispersive electrode. When the energy delivery to this tissue has occurred, you are eventually going to have a denatured area where the resistance rises. So when you are reapplying cautery at this point, you are not going to be able to conduct electricity as well. So sustained power delivery is not going to bring about any significant change. Let that sink in for a bit. Now say you have a metal prosthesis between where you are applying energy with the monopolar current and the dispersive electrode, or you have something like a staple line within your surgical field. Well, at this point, when you're sitting and applying energy, the same rule applies. The current density is definitely going to be the highest at the point of energy application by the cautery pen, and it reduces going beyond. So you are definitely going to be forming an eschar. But note that the metal prosthesis or the staple line which is present over here is never going to form an eschar, right? It is only the surrounding tissue. So this metal is going to continue conducting electricity, and this current is going to zigzag all the way across down to the dispersive electrode. Now, because the electric current is moving along the path of least resistance, and because this metal is never going to stop conducting electricity, all of the tissue that is present around this area now gets denatured, and you'll end up having much more energy delivery within the tissues at a much deeper level than if you did not have this metal intervening. When tissues get charred, you can have temperatures of say 200 degrees Celsius. You may have some carbonization at that point, but it's doable. It stops conducting electricity beyond that point. But metal never stops conducting electricity, and they have been noted to have temperatures as high as 1000 degrees Celsius. So they will keep heating up the tissues in its vicinity and keep causing problems in your surgical field. So whenever you have these sort of patients, a staple line within the surgical field, a prosthesis made out of metal, and indeed a pacemaker, you should be extremely scared to use monopolar energy in these patients. Direct coupling is utilized in monopolar energy to our advantage, but in laparoscopic energy, that sometimes happens to our detriment. If you fire your laparoscopic hook or spatula or Maryland forceps when it is beyond your surgical field, you may land up inadvertently touching one or the other ports and land up causing damage there as a result. Or even worse, you may have that metal trocar then coming into contact with some visceral structure and land up burning that. So direct coupling is an advantage in open surgery, but a very, very problematic issue in laparoscopic surgery. So this is a patient where there is a problem with the insulation of the laparoscopic hook that is being utilized, and you can see the spark that got generated just by having another device close to it. Clearly, there is a coagulating current which is being used. I'm just going to show you that very quickly again. So they are trying to take the GB off the fossa. You can see there's already sparking happening, and there's a big spark when it comes in contact with the grasper. So this right now at least is happening within the field of view. When it happens beyond the field of view, you're risking all sorts of damage which is going to go unnoticed at the time of surgery. To check the insulation of devices, you have these insulation checkers. You essentially connect a monopolar current across the device, and you pass the device across this little loop that is present over here, and it checks if any current is able to spark across the insulation within this handheld device over here. So if any current is leaking, then that insulation needs to be changed immediately. Never use any lap instrument where the insulation is dicey. You may land up having energy related injuries very far away from where you're actually working in the surgical field. I've given you a small amount of background about capacitors earlier and its use as far as the dispersive electrode is concerned, and as to how we can turn the patient into a capacitor rather than completing a circuit around them. Well, there is another important place where capacitors are created by us inadvertently to our detriment. Let's see how. First and foremost, a capacitor is two conducting areas, left and right, that you see over here, separated in the middle by an insulation. Okay, very important. So it's essentially an insulator that is sandwiched between two areas that can conduct. All of our laparoscopic instruments have an inner conducting core with an insulation on the outside, and the tip is always uninsulated because this is where you want all of the energy to be delivered. When you pass these laparoscopic instruments through a metal trocar, you are essentially creating a capacitor of sorts. One end of the capacitor is a metal trocar, the other end is the inner core within the laparoscopic instrument, and the non-conducting sandwiched area is the insulation on the laparoscopic instrument that you can see over here. I hope that is clear. The creation of this capacitor though does not cause too many issues. It can hold charge, but because the laparoscopic ports are going through the body wall, the current density is never high enough when the energy is dispersed to actually cause the patient any significant problems. But imagine we are sitting and using a disposable plastic non-conducting trocar. Well, now we don't have any capacitor in play, right? Because we only have the insulation with the conducting area within. But sometimes these disposable trocars land up having a faulty valve, and we'll end up using a metal reducer within them to take care of the CO2 leak which is happening. Now do you see how a capacitor has been created? Additionally, because of the insulation that is provided by this plastic trocar on the outside, this non-conducting sleeve, the charge cannot be dissipated across the abdominal wall. Instead, the tip of the metal trocar can now come into contact with any of the surrounding visceral structures and disperse the energy that is built up within the capacitor, and this is termed capacitive coupling. You can have bowel that comes into contact, and this is again going to be happening very far away from the working end of your instruments. So mostly this is going to be happening out of view, so we need to be aware of this. So the trick to preventing capacitive coupling is this. Use entirely plastic trocars without a metal reducer within them. Avoid using short plastic sleeves on the abdominal wall with metal trocars on the inside. This is particularly true of some surgeons who end up using a plastic Hassan's cone with a metal trocar within them, because that again lands up creating a capacitor. Avoid using extremely long metal reducers. Instead, you can use these flip-top reducers that convert your ports from 10 to 5 millimeters instead. Because they are present only at the top hub of your port and they never go across the entire length, you are having an added layer of safety, and you don't land up having this capacitive coupling that I've discussed earlier. Okay guys, let's move on to ultrasonic devices right now. So why are they called ultrasonic? Because they have a frequency range that is beyond our hearing range, that's beyond 20,000 Hertz. Now, when we are using ultrasonic devices for imaging, that's the ultrasonography machines that we have in our radiology department, they are functioning in the 2 to 18 megahertz area. Alright, that's their usual frequency. But the ultrasonic devices that we are using at the time of surgery have a much lower frequency of 23 to 55 kilohertz. That's 55,000 cycles per second. And essentially, it's happening at this working end of the ultrasonic energy device. There is back and forth movement. Electrical energy is converted by means of a piezoelectric crystal into this to and fro oscillatory movement that happens at the business end of the instrument. Note that only one jaw of ultrasonic devices is always going to be articulating. So you only have a single action jaw. This lower jaw is the one where ultrasonic energy is delivered, and it is always in line with the shaft of the instrument because it is at the probe end or the handpiece end that the energy delivery is changed. And this is the direction of the oscillation that occurs. It is to and fro in line of the long axis of the instrument that is present. Now, obviously, because there is to and fro oscillatory movement, there's going to be friction, and that friction is eventually going to be producing heat. And this is what lands up happening. When you close an ultrasonic device on top of a vessel and you fire the energy across, the to and fro oscillatory movement lands up creating friction within the soft tissues that are contained. And with the coaptation produced as a result of closing the instrument upon itself, you'll end up having intima to intima apposition. Eventually, thermal energy delivery leads to the production of an effective seal, and that gives us hemostasis. So very quickly, there's friction at the end with some vaporization that occurs as a result of heating tissues close to 100 degrees Celsius, and cavitation occurs. Cavitation is essentially dissection that is facilitated by vaporization. When fluid within the tissues is vaporized, it lands up dissecting within the tissue spaces, causing the tissue to flare out and open up a little further. So that's the cavitation that we are sitting and talking about. The vessel sealing occurs as a result of coaptation. We've covered this. The proteins get denatured. There is a coagulum that forms across the intima. This is the same mechanism of action as a vessel sealing device, a bipolar vessel sealing device. But the main difference is this entire magic is happening by means of physical friction rather than friction caused by the oscillation of electrons. When you are using an ultrasonic device, there is no electricity that is flowing across the patient. Whereas for monopolar and bipolar devices, there is electrical energy that is flowing across the patient. In ultrasonic devices, the maximum temperatures that are reached are just beyond boiling point, so close to 105 degrees. So you never land up having carbonization of very strong eschar formation within these ultrasonic devices. That being said, you do land up having some amount of sticky soft tissue that gets caught within the active jaw of these devices that needs to be cleaned, but it is not the same eschar that you will see in monopolar and bipolar energy. Usually these devices come with two settings. The setting does not change the frequency of oscillation. The frequency is fixed. For example, harmonic scalpel produced by Johnson & Johnson has a fixed frequency of about 55,000 Hertz. In contrast, a Thunderbeat produced by Olympus is going to be having a fixed frequency of close to 27,000 Hertz. Changing the minimum and maximum settings in these devices does not alter the frequency. Instead, what gets changed is the amplitude of the oscillation which is occurring. When you're using at the minimum setting, usually it's a 50 micron to and fro oscillation that occurs that produces extremely good hemostasis, does not have a cutting effect, but the amount of lateral thermal spread lands up increasing. Now, this is kind of similar to what happens even in monopolar energy devices, right? If you don't stretch the tissues enough, don't reduce the resistance enough, energy gets dissipated to the surrounding tissues and you'll end up having lateral thermal injury. In contrast, when you have a maximum excursion of the active blade, which is usually around 100 microns, you get less hemostasis, but the tissues get vaporized and get cut very, very effectively. On the flip side, the amount of lateral thermal injury is much lower. So collateral damage less when you're using the maximum mode, but tissues are going to be more likely to bleed because it does not produce effective hemostasis. Ultrasonic devices have all sorts of use in surgery. This is me using it to create an enterotomy. You can see the vapor that is coming out from use. The tissues do not have any eschar. Now I'm going to be using the active blade to essentially penetrate across, using it like a scalpel, if you may, to create an enterotomy in this case. So you can always use the active blade to just hold up tissues and fire the blade to cause some amount of division, or to enter tissue planes, the active blade can be used with the jaw open. The special tips for use of ultrasonic devices, because there is a lot of variability in the effect you get from these devices between different surgeons. It needs some level of skill. The greater the amount of pressure is applied, the greater is going to be the cutting efficiency. So if you're holding the jaws very close together, the cutting efficiency increases. If you're holding them wide apart, cutting efficiency is going to be much lower. The tissues are not at stretch. Lower pressure will result in lower cutting and greater coagulating efficiency. So if you're holding a vessel, you want to keep it just apart, not entirely press the tissues down, because your cutting effect is going to be increased, and you want to be using the minimum setting on the ultrasonic device to be able to get good hemostasis. If you want to create an incision, say peritoneal flaps or enterotomies, place the tissues under significant stretch to have maximum cutting efficiency. I have an analogy for this. This gentleman is holding the board very well and firmly, as a result of which, this is a comedian over here, Conan O'Brien, he's able to punch through it very, very effectively despite not being a martial artist, correct? The work is not being done by this dude over here, but all the important work is being done by this guy who's holding that board in a firm manner. In contrast, when you're not holding the board firmly, you'll end up having weird energy that gets dissipated all over the place. With that in mind, I'm going to leave you with the last pro tip of this lecture, is that whenever you're using ultrasonic shears, always keep the tissues at a firm stretch, as you can see is happening in this clip, to be able to get good cutting efficiency. Otherwise, you will only get hemostasis and not much else. Alright guys, that brings us to a close, and I'm pretty sure with everything that's being discussed today, you guys feel like you're masters of energy. I really do hope that is the case. I firmly feel that the principles that we've discussed today are not difficult to master, and some investment of time and effort in this direction is going to produce significant changes in how you are using these devices in the operating room. You're going to be able to employ or rather enjoy not just greater competence, but you're going to be also having higher confidence. There's no surgeon who can achieve true mastery over his craft without using the energy devices in a consistent and safe manner. With that, I'm going to wish you good outcomes with all of your patients.